but it really nicely brings to Dr. Elizabeth Finch for us to give us a talk on neuro-oncological aspects of medulloblastoma. I know that many of us say that, clever doctors, and then we somehow stop thinking, at least certainly me, after surgery. But Dr. Finch, I'm certainly greatly looking forward to your talk. Thank you.
Thank you. All right, so thank you so much for inviting me to talk today. I have one disclosure, but it's not relevant to today's talk. So we've gone over, the background of medulloblastoma. So in the interest of time, I'm going to skip some of this. But what we do know is the prognosis for localized medulloblastoma is 70 to 80% these days. So it is still not perfect, and there are still lots of areas for improvement, but it is better than it has been. However, for metastatic disease, there's only a 50% cure rate. So definitely localized tumor is much better. And then in most Wnt subtypes, the cure rate is greater than 90%. So we'll talk about some of the changes to therapy for that. We've seen different ways of looking at this. The main things that as an oncologist I want to know is really the subgrouping. The more intricate subtypes right now for your standard patients are not really taken into account for treatment. So those big 4 subgroups are really what we want to know. For treatment-wise, like we mentioned before, really if you can get an upfront gross total resection, that is the best. However, I agree completely that you want to do that not at the risk of causing neurological damage. So it's a fine balance, and I am glad I'm not a neurosurgeon because it's I think a tough choice of how far to go and how aggressive to be with your resection. For most children, as long as they are greater than 3 years old, we usually recommend starting with radiation therapy. Most commonly, what we recommend here in the US is to do proton therapy, but your intensity modulated photon radiation therapy can work well as well. The biggest thing is you're trying to reduce damage to your normal tissues. For average risk patients, and we'll talk about what makes you average risk, we usually see about 23.4 gray craniospinal radiation being used with a boost to the primary site to about 30.6 for a total of 54 gray. For higher risk, there is a higher dose of CSI to 36 gray and then boost to the primary, but you're still getting your total of 54 gray. In terms of treatment, what I think about is what is my subtype. So for your Wnt subtype, usually that's going to be your children greater than 3. Some of the common mutations we see are beta-catenin and monosomy 6. It's also the tumor type that you may see in someone who has Turcot syndrome, which is the APC gene. And usually these patients do well. So there's currently a trial through the Children's Oncology Group, ACNS 1422, and it's looking at reducing therapy for the Wnt subtype medulloblastomas. So this is just for the patients that are older than 3, do not have MYC or MYC-in amplification, don't have metastatic disease or a large residual, and they can't be anaplastic or nodular desmoplastic. And what they're doing is they're decreasing the craniospinal radiation down to 18 gray. So you're still getting the total of 54 gray, but you're not getting as much craniospinal exposure. And there's no vincristine given during radiation, which there usually is for the other types. And then after your radiation therapy, you get a 4-week break and then 7 cycles of maintenance. The way that the maintenance is, it's similar to what you would use for a standard risk patient, but in less number of cycles. Some of the cycles you can see it's alternating between your A and your B cycles, with your A cycles using cisplatin, lomustine, and vincristine. We see with that combination of chemotherapy, you can get hearing loss. There is a lot of nausea and vomiting. And your lomustine or CCNU has a long half-life, so usually these patients won't nadir until closer to 4 weeks, and so these cycles have to be longer. Your B cycles include your cyclophosphamide and vincristine. And so then once you take away the Wnt subgroup, you have your sonic hedgehog, group 3 and group 4. And a lot of times we kind of lump these together to treat them. I think we've talked about how your sonic hedgehog really can have a good prognosis if it's in an infant, but not such a great prognosis in the older age. Group 3 is usually going to be your younger males. There's not really a specific mutation that makes up this category. So a lot of times up front, you'll get from pathology, it's Wnt, it's sonic hedgehog, or it's group 3/4. So you do need to send methylation for that. And if they're MYC amplified, they have a poor prognosis with a 5-year overall survival of only 32%. And then your group 4 is your children and adolescents. Sometimes you'll have a mutation such as a CDK6 amplification or your isochrome 17q, and these are usually an intermediate prognosis. So treatment is based on whether they have high risk features or not. So to be considered your standard or your average risk, you can't be metastatic. You have to have negative CSF. And that CSF really needs to be done either prior to surgery or greater than 10 days after. So you're getting a true sample and not stuff that may have been leaked during the surgery. And then they still do use in the protocols, a lot of times the 1.5 centimeters residual tumor would make you a higher risk. So for standard risk, we typically use one of the COG protocols, ACNS 0331. It is no longer enrolling, but we use the schema for it. You have upfront radiation, and with radiation, you get weekly vincristine, and then you have maintenance therapy. It's the same medications that are used in the Wnt study that's going on, but instead of 6 cycles, you get 9 cycles, and it's 2A, then a B, 2A, B, 2A, B. And so it takes about a year total for this treatment. And this is just for your children greater than or equal to 3. We'll talk about the younger ones in just a second. 5-year event-free survival is about 81%, and the 5-year overall survival is 85%. If they're higher risk, so those who are metastatic, had residual or positive CSF, there was a study, ACNS 0332, and this is when it became important to know the group 3 versus group 4, because they found in this study that those group 3 patients, when they had radiation, if they were given daily carboplatin for a total of 30 doses, in addition to weekly vincristine, they did better. So the carboplatin act as a radiation sensitizer, but only in your group 3 patients. Your other subtypes, so your group 4, your sonic hedgehog, they still will get weekly vincristine during radiation, but the carboplatin did not help. Maintenance for these higher risk patients after radiation is usually 6 cycles of chemo. They're each 4-week cycles. You get cisplatin, vincristine, and cyclophosphamide. So it's more intense, but a shorter number of cycles than your standard risk. The event-free survival for these patients is 62.9%, and a 5-year overall survival is 73%. Now, what about your patients that are less than 3 years old? So your sonic hedgehogs are going to be the majority of your infant medulloblastomas. And they found that if they were non-metastatic, they did very well when they were treated per one of the German protocols, your HIT 2000 trial. This used a combination of systemic chemotherapy and intraventricular methotrexate, and actually had a 5-year overall survival of 100%. It's 5 total cycles of chemo. They get methotrexate intraventricularly through an Ommaya, and then systemic therapy consists of carboplatin, vincristine, etoposide, methotrexate, and cisplatin. Patients less than 3 with other subtypes, really we recommend a clinical trial. And the goal is to use chemotherapy to either avoid or delay radiation therapy because of the neuropsychological deficits that can be caused by radiating such a young brain. Currently at our institution, we have a trial open called Head Start 4. It uses 3 cycles of induction chemotherapy. You then have a response evaluation, and if you have residual disease, you can either go on to a second look surgery or get 2 more cycles of induction. And then it's randomizing between 1 cycle of consolidation with high-dose chemo and stem cell rescue or 3 cycles of consolidation. And then after that, based on your age and other risk factors and response to therapy, they determine if you get radiation, with the hope that by that point you would be greater than 3 years old. The induction cycles are cisplatin, etoposide, vincristine, and then high-dose methotrexate. And your consolidation cycles are carboplatin and thiotepa, followed by stem cell rescue. It is a pretty toxic regimen, just because of the amount of high-dose chemotherapy and the amount of kidney injury that you can see, especially with the cisplatin, and then followed by the high-dose methotrexate. So some other kind of hints for medulloblastoma treatment. So there is a medication, vismodegib, which is a small molecule inhibitor of sonic hedgehog that is being considered for relapse disease. We haven't been using it as much upfront, although there is a trial at St. Jude, SJMB12, that's looking at using it. The problem with this medication, it does close your growth plates. So in children who haven't stopped growing, they will literally stop growing prematurely, which can be an issue. Studies have shown that giving chemo before radiation, so this is like in your older children, it didn't improve survival compared to giving the radiation and then the chemo. So our standard is still for the older kids, radiation first, followed by chemotherapy. And then your high-risk medullo and older children, some centers will treat with 4 cycles of high-dose chemo. It's usually cyclophosphamide, cisplatin, and vincristine, and then stem cell rescue. The 5-year event-free survival for those patients is around 70%. They still get radiation up front, but that's another way to treat them that has about the same survival. Relapse medulloblastoma, about 20 to 30% of patients will relapse. There's equal distribution between those who relapse locally, distant, and then a combined, both local and distant. If they received craniospinal radiation up front, there are very few survivors because there's not a lot of great salvage regimens. If they've not received radiation, then they could give radiation and there's greater chance of survival with that. Some of the salvage regimens that can be used, so combinations of temozolomide, irinotecan, and bevacizumab. There's also metronomic chemotherapy, which uses alternating doses of etoposide and cyclophosphamide with the addition of bevacizumab, thalidomide, fenofibrate, and celecoxib. But really, we recommend clinical trials for relapsed medulloblastoma. Some examples of these, at our institution, we have the Beat Childhood Cancer 016 open, which is for relapsed refractory medulloblastoma. After you get some salvage therapy, you then go on DFMO to try to prevent the tumor from coming back. There's a PBTC 053, which is looking at using one of the sonic hedgehog inhibitors, CX4945, that's specifically for your recurrent sonic hedgehog medulloblastomas. And those are just 2 examples of some of the trials, but really for relapse, we do recommend a clinical trial. So in summary, if we can get a gross total resection, that's great. Radiation closely after surgery allows the best survival, but is really not recommended in those 3 years and younger. We try to delay it with chemotherapy if possible, and relapsed medulloblastoma should really be treated on a clinical trial. These are my references, and I am happy to take any questions.
That's brilliant. Thank you very much for this very useful overview for us neurosurgeons. I think with all the molecular subgroups coming, I think the work of neuroscience is not going to going to get a bit easier, but certainly the neuro-oncologist's life is going to be very, very busy because run up to this, I've been trying to read up on medulloblastoma, molecular biology, etc., etc. And even if you look at that book from 2021 on the last WHO classification, the sheer combinations and permutations of molecular signatures and then their prognosis and the implications for treatment, it's going to be, the next one is going to make it even harder. My first question to you, Dr. Finch, is that in terms of this personalized therapy, the immunotherapy, are there any trials going on, or is that still early days for medulloblastoma?
There are some trials, but I would say at this point, it is really still early days. So for relapsed refractory, you might see more of the immunotherapy. I have not seen it a lot in your upfront therapy for medulloblastoma.
Okay. Second question is that I understand with the low risk ones nowadays, there's even cure possible. And with the chemotherapy and radiotherapy, are these children, are they basically infertile, or what happens after chemotherapy, radiotherapy on that regard?
Yeah, that's a great question. So a lot of the infertility issue is going to come from your cyclophosphamide. Luckily, a lot of our patients because they are younger, they do still have some reserved fertility. I don't know the exact percentage numbers, but I think it's more the cyclophosphamide exposure that's the issue more so than the radiation.
Thank you. Mr. Sinha?
Agree, and may I add one thing that actually that's also one of the many motivations why we prefer, like Dr. Finch alluded to, proton CSI as opposed to photon CSI, especially with the involved field boost. There would be a very high dose beyond the tolerance of the hypothalami and the pituitary gland with photons as compared to protons.
Okay. So it hits both sides, both the cranial radiation as well as the chemotherapy side of things as well. Great, thanks. Mr. Sinha, your thoughts and questions for Dr. Finch? Thanks.
I think excellent talk. I learned so much today. I mean, our job is to get the patient off the neurosurgery ward as quickly as possible. I know they're getting chemotherapy, radiotherapy, but you don't go into the extreme end of what's going on with this patient. Just a quick question for older children who are extremely poor grade, who are poor grade. Is there a role for just radiotherapy with temozolomide? Is there something being proposed, being done?
I have not seen that for medulloblastoma. I've seen that a lot for the diffuse midline gliomas or high-grade gliomas, but they're really need more of the combination chemotherapy for the medulloblastomas.
Sure. Thanks so much.
Totally agree, and I think the language in some of the most recent clinical trials for relapsed recurrent medulloblastoma allows for concurrent temozolomide with radiation in the salvage setting, hoping to build upon this synergism or radiosensitization effect of temozolomide. But like Dr. Finch mentioned, we don't have enough data to confirm that there is an added benefit like in high-grade gliomas.
So much. Thank you so much.
Thank you. Dr. Jason Chiang, I think from the neuropathology point of view, questions to Dr. Finch, thanks.
I think that was an excellent talk. Just to have an overview of all the treatment approaches and options for all the medulloblastomas. And as Dr. Finch mentioned, the major molecular groups of medulloblastoma is really what's really needed, most important information for treatment, triage, and stratification. So as in Jude, we usually try to give those information as fast as we can, especially sometimes we get the specimen weeks after surgery as a consultation. So in my practice, I usually sign out medulloblastoma with major molecular group information the next day, just so the oncologists and our neuro-oncologist, the radiation oncology friends can treat the patient as soon as possible. And the methylation is really helpful to distinguish all the 13 molecular subtypes. But as Dr. Finch mentioned, most of the subgroup therapy are still experimental in clinical trial settings. So even though it takes 2 weeks to 6 weeks to get the methylation results back, the impact, at least at the moment, for patient treatment is still questionable. So that's just something I would like to add. Thank you.
Thanks, thank you. Dr. Mukherji?
No, I think that was a fabulous talk. Just one thing, Aaron, I'm going to have to sign off pretty soon because I have to get to my meeting. So thank you very much. I think one thing that I did want to say was it is important to understand the medications, especially the patients are on some type of immunotherapy. So that if they are on bevacizumab, which I believe is a VEGF inhibitor, that can actually lead to a pseudo response on postoperative imaging. So one thing about the anti-VEGFs is that they can actually reduce the enhancement. So if you do postoperative imaging or post-treatment imaging, I should say, and you don't see any enhancements, sometimes that can give you a false sense of security. So when you are evaluating these patients and they are on some type of immunotherapy, it's important to know which type of medications they're on to have the most accurate assessment of post-treatment imaging.
That's great. Thanks. Thank you. Dr. Jallo, are you able to join over the microphone? Dr. Jallo has posted a question. What option for salvage therapy at the time of recurrence, Dr. Finch?
Yeah, the best thing is clinical trial. Irradiation, if they have not had radiation, you can definitely do that. But really there's not a standard of care for relapsed or recurrence. So if you can get them on a clinical trial, otherwise there's a bunch of different chemo methods that have been tried. None of them are super successful. I do like the metronomic chemo because then you're hitting the tumor from different ways, both the cytotoxic and you looking at decreased cell proliferation with like your VEGF and your thalidomide. And it is a regimen that's well tolerated and patients don't have to be in the hospital. But it's not really going to cure them. It's just going to maybe give them some more time. But yeah, we really are looking for ways to improve recurrent disease. And like Jason said in the chat, there are different trials. There's at St. Jude, they do have a CAR T trial. So really looking at immunotherapy methods for recurrent disease. We don't have a good solution yet.
Thank you.
Totally agree. And I would add, like, it also depends on like the extent of the recurrence and whether it's focal versus intracranial versus leptomeningeal dissemination, which is awful, of course. But it depends, especially if it's outside the resection cavity, the rear radiation. And with advances in radiation, including stereotactic radiosurgery, we can deliver like quasi-ablative therapeutic doses. But of course, if it's leptomeningeal disease, it's more of palliative. And either way, like clinical trial enrollment is highly encouraged.
Thanks. In US, Dr. Hisham, is now proton therapy the standard for standard care for medulloblastoma, local radiotherapy, radiation treatment, or what's the policy nowadays nationally?
It's encouraged if it's available. We still like proton therapy are not available like nationwide, of course. Here in Boston, for example, there is availability for proton therapy. So if it can be delivered in a timely fashion, that's something that we definitely encourage for. But this might be complicated, especially with kids with posterior fossa syndrome, where there will be like a lot of competing needs here. And especially with the advances in photon radiation with VMAD, volumetric modulated arc therapy, we can deliver radiation with comparable risk-benefit or like risk-benefit ratio, but still if proton is available, that would be our top choice. And I would also add, like I want to allude to one of the clinical trials that I think hasn't started accruing yet for like the use of radioprotectants, like sodium thiosulfate in order to protect the cochlea, because again, proton can spare the cochlea to some extent, but we're hoping like for even better sparing because the combined effect of radiation and the platinum on the cochlea and the long-term hearing deficits is still like at an unacceptably high rate.
That's great, thanks. Dr. Finch, it's really fantastic talk. I think, for neurosurgeons, when I'm sitting in this MDT meeting, the minute after the neurosurgical side, once the radiologist, once an oncologist and the radiation oncologist start to talk, I kind of, go into the world of ignorance. I think it would be nice that every 4 months that the MDTs spend one day that they teach each other the basics of each other's art, because I know that my oncology colleagues love it when I talk to them about neurosurgical sides, and but I really managed to get oncologists in time. They are usually very busy. But I think these MDT meetings, I think to be really useful, it will be good for each others to actually have a basic understanding. I know that when I'm saying basic understanding, I don't know how much understanding. I think it would be good for you guys to do a survey on how much neuroscience know about oncological management and vice versa. I think it will be good to have, so that they all have at least a bridge to talk on. I don't know. What do you think, Mr. Sinha? Am I exaggerating my ignorance, or do you think there's a combined teaching of basics is useful?
No, I couldn't agree more. I mean, we tend to be in our own little silos, isn't it? We do get some cross-fertilization of ideas, but it's largely limited to meetings like what we are attending today. I mean, that's how I maintain my CPD.
Thanks, thank you.
Or everyone can tune in into these incredible grand rounds, right?
Yeah, absolutely. Thanks. And also, not they have to be very deep, but the basically at least the big islands, so that then you can go. I think we have got Dr. Chiang. In terms of where are we going with neuropathology, in the sense that one of the thing I want to ask Dr. Finch before that, Dr. Finch, how much difficulty you have with the neuropathologists taking their time to give you the full analysis before you start the treatment, and how much issue you get from the parents? Thanks.
Yeah. So really, we have great pathologists, and we're able to get that, basic information of whether it's Wnt or sonic hedgehog or group 3, 4. The problem is waiting for methylation, because there are only so many places in the US where they even do that. And so with shipping things out and then getting the information back, it's tough. In a lot of clinical trials, you have to have that information within 31 days of surgery so they can start radiation. And there are a lot of times where we're day 27 to day 28 where we don't have those results yet. So it can be tough, and families really want information, especially in our age of, instant gratification and internet and all of that. So we just, I try to tell them upfront, it may take several weeks before we have the information back.
That's great. Thanks. Dr. Chiang, from your pathologist point of view, is it important? I know for probably most of the patients are in one of the trials, but you can do just immunohistochemical analysis to find which subgroups they are. Is that right?
Yes. So the bad news is it's going to get worse and worse for neuropathology. It will make the job harder for everyone, because now the more we do for the molecular analysis, methylation, NGS, and other fancy technologies in the future, and the splitter seems to dominant in the field. So we are going to cut the pies like smaller and smaller. Before we have only measure PNETs, and now PNETs does not exist anymore. We have so many different entities. And before we only have medulloblastomas, and we started to separate them into 4 different buckets: Wnt, sonic hedgehog, group 3, and group 4. And now we have 30 molecular subtypes in combination with different histologies, in combination with MYC and amplification status, in combination with p53, isochromosome 17q, metastasizing or not, subtotal resection or total gross total resection or not, and the age of the patient, etc., etc. The decision tree is really complicated. So, and it's not going to get better soon, because many of the therapies are still experimental. We will have to wait for 5 to 10 years before we know what's the meaning of all this. So in our practice, we try to balance what's useful, really useful, proven to be useful, from what's experimental or maybe wishful thinking or maybe therapeutic potential in the 5-10 years down the road. So as you said, histopathology is still quick. By histology, you can tell whether it is a medullo or ATRT, ETMR, high-grade glioma, ependymoma, or other tumors rather fast, within a day or 2. And by immunohistochemistry, the YAP1, GAP1, and beta-catenin combination, we can tell the Wnt, sonic hedgehog, and non-Wnt non-sonic hedgehog, those 3 buckets, in a few hours to days. So usually, as I said, I sign the case the next business day. Medulloblastoma Wnt activated, or medulloblastoma non-Wnt non-sonic hedgehog, and then see comment. I will comment on histology, whether it's classic, which is good to moderate depending on the molecular subgroup, or desmoplastic nodular, which associate 100% with sonic hedgehog molecular group if diagnosed correctly, or large cell anaplastic. It's still a risk factor. And then the radiologists can tell us it's metastasizing or not, and surgeons can tell us it's gross total resection or not. And then the oncology can judge from the patient perspective what's the best available out there. So that will be that. With that approach, we can cover most of the situation. And the methylation is used more and more useful. And as in Jude, we try to get the information quick. I know some places takes a month or 6 weeks. And we try to cut the turnaround time down to 10 working days. That's about 2 to 3 weeks. So we are still trying to improve that, but since it's a complex technology, it's going to take time. And it's even worse for NGS because once you do whole genome, whole exome, and RNA sequencing, the analysis pipeline will need to compare germline, and it's complicated. It needs manual review, plus the library preparation, the DNA RNA extraction, the actual sequencing process, the computational pipeline. But in the end, we have to realize how much information we really can get from all these complex technologies. And we also have to consider the cost aspect of this. At St. Jude, everything is free, but I know it's not free elsewhere. It may cost the patients, the parents, thousands of US dollars, and not to mention to the rest of the world. That would be a big burden for them. So yes, it's going to get worse, but yes, we have good solutions for that, and we have practical solutions for that for our oncology, radiation oncology colleagues, and also for patient and parents. So long answer for a complicated question.
Thanks. Thank you very much. It's very helpful. I think Dr. Jallo had a lovely slide where he showed the different molecular pathology for different ages. It was a beautiful one. And in terms of, you know, when you read the literature, you have got that gene, this gene, that gene in 10%, this gene 15%. And how many patients, how many samples are they using? And is this, you know, at what point is it going to be significant, and at what point it is not significant? So, you know, the number of cases before you can do all these things. I'm just wondering whether, I'm sure you have got neuropathologists have a robust system to say which is significant things, which is significant molecular signature.
Yes, the case number is probably not an issue for medulloblastoma because it's probably the most common pediatric embryonal tumors. So the studies that at least at St. Jude have thousands of medullos to tell those molecular alterations, and there are so many of them, but there's hope because there are only a few that we really want to remember for now. For example, as Dr. Finch mentioned, the Turcos syndrome, APC, which can be germline. So cancer predisposition that we want to follow up with the genetics team. That's important to know. P53 is prognostically significant for the hedgehog medulloblastoma, and which can be germline, lymphoma. So that's something we want to know. ALP1 for the sunny hedgehog medulloblastoma, which can be germline. It's probably the most common cancer predisposition gene for medulloblastoma, and it's enriched for the sonic hedgehog group. So that's something we want to know. And others like Golden syndrome for hedgehog medulloblastoma, that's something we want to know because you want to make sure you don't radiate them and get basal cell carcinoma in the radiation side. That's something we want to know. And others are either not specific or just happening in a subset of the patients, and whether they have therapeutic implication or not, that's still questionable. So even though the list is known, I think practically we at least we only need to remember a very subset of them for now.
That's brilliant. Thanks. Thank you. Dr. Hisham Elhalawani, in terms of radiation oncology, what's the next step? What are the advances coming to improve its effectiveness and safety?
Thank you. So yeah, I think all eyes are on the newest COG study, the ASCNS 1422, because we had an experience in the past that didn't go really well with dose de-intensification for what we still call like low risk or standard risk, average risk or standard risk medulloblastoma. So now with like the introduction of Wnt activation and trying to refine the criteria by which we define the lower risk patients, I think that's going to be very helpful. As I mentioned, proton therapy is important in order to, even with the CSI, in order to spare the hypothalami, the pituitary gland, the optic apparatus. That's really important. and the use of radioprotectants like sodium thiosulfate in a clinical trial setting is postulated to even help further spare the hearing function in these kids. I just wanted to add that because we don't usually take the decision to irradiate lightly, because we always have vibrant multidisciplinary tumor board discussions like the one we're having here in the grand rounds. And we also have a survivorship clinic. So we know and we see what are the long-term impacts of radiation down the road. It's just interesting, and I think it merits like a grand rounds on its own to discuss infant medulloblastoma, because I personally have noticed that there is some sort of an age cutoff migration for what constitutes an infant, depending on the disease site and depending on the advances in surgery and systemic therapies. So it's getting infant medulloblastoma definition is getting older and older for medullo, as opposed to some of like the more unfavorable PNETs like ETMR or ATRT, where an infant can be as young as 9 months old for supratentorial ETMR.
Thanks. Thank you very much. My last question, Dr. Hisham Elhalawani, is that in terms of the secondary tumors, what in terms of when you consent patients, what do you quote as any figures of secondary tumors, and what are the common secondary tumors then?
Yeah, that's an excellent question. And so it's interesting because radiation-induced second cancers, so it's more common in high-dose areas, but there is some sort of a stochastic, non-deterministic relationship between radiation and the risk or incidence of secondary cancers. So it's not uncommon that we see secondary radiation-induced cancers in the CSI region, not within the area that received an involved field or a posterior fossa boost. And of course, the most common are going to be either like high-grade gliomas, or even more commonly, it would be a meningioma. And usually we try to say, and there have been like contradicting results out there in the literature about whether protons have like cancer, like are associated with lower risk of cancer, radiation-induced cancers. And depending on which retrospective study you're looking at, you will find conflicting results. But I think the jury is still out, and I cannot see with confidence that proton is associated with lower risk of radiation-induced cancer.
That's brilliant. Thank you. Thank you so much to Dr. Jallo, Dr. Mukherji, and Dr. Finch, and the faculty, Dr. Jason Chiang, Dr. Hisham Elhalawani. It's really been very useful. I hope you have found it useful. And it's a really good reference as well. And, there are lots to take in, unless you have got the brain of a supercomputer. And it's nice that it's all recorded. In the next 3 or 4 hours, I will send you the link so that you can not only watch it, but you can just download it, download the videos if you want to for your, you can look at it. I think one of the things that I found is that with the AI, as in not the AI that you'll be using soon in hospitals, but the AI that I have access to, which is ChatGPT, or the best one is actually called Perplexity. It's unbelievable. It will solve you from physics to oncology to neurosurgery, and it will give you images and videos, and it's called Perplexity. Perplexity.ai. The old days when I used to read neuro-oncology, or if I used to read even neurosurgery, complex neurosurgery or neuropathology, you are stuck. You have to do Google search, or then you have to look at which page is right, this and this. And nowadays, I tell you, I've got 2 screens, and on one screen I have my a system called a British company called, and they haven't given me any money, called Raycast. It's unbelievable software. And then if the £8, free is very good. £8 is fabulous. But when you pay the £16 worth, you wouldn't believe it gives me 6 AI models. Okay, ChatGPT, the one from Meta, the one from Claudia, and another one called Mextra. And then I get for 6 months free Perplexity. And I tell you, then you just set yourself a keyboard shortcut, and you just click it, and it just comes up, and you write it, and then you work along with it. So I think that, the things that we used to, rush around to find out, or, we would never be able to find out something neuro-oncology. even just to know the lexicon, but they are very, very good. So my advice is that I started internet early on when internet came. It took about 15 years to actually mature and be useful. But with this AI, that I'm talking about the consumer AI, within 1 year, I have done things that I would not even imagine. So, I think you should, my advice is that be open about this AI, the ChatGPT or Perplexity or these things, because anyone who can actually use these things, they are going to just gallop away, and they are not difficult. It's just getting the mind to it. So that's just a side, but I really thank all the participants who joined, and I'm grateful for the faculty and the speakers, and I hope we will meet again. Thank you very much, and wishing you a great rest of the weekend.
Thanks,
everyone.
Naren. Thanks so much.
Thank you.
Sorry, I
Thanks.
have to leave now. They've just called me now.
Oh, good. Have a great surgery. Thank you.
Thank
Cheers.
you.
Thank you. And thanks,
Thank
Dr. Naren, for coordinating this.
Oh, privilege.
Bye-bye.
Privilege. Thanks a lot. Thank you. Thanks, Dr. Finch.
Thank you. Thank you.
Thank you, Jason. Cheers.